Today we are continue our series of complex total knee surgery, and today we will gather to, with the how to exclude mechanical failure and looking for the pain post-operative in total knee arthroplasty. Welcome, Dr. Mahmood Shihab. Thank you very much for your support and for this lecture.
Thank you very much, Dr. Sinan. Thank you very much for my colleague. We are sorry that last week we have other webinars, so I cannot attend fully my lecture. Today we'll continue in our series, and something is related to the infection, but it is a guideline for everyone working in the aspect of total knee replacement, how to exclude mechanical failure in good-looking painful knee. I will later discuss in details. Just I want some highlights to those not attend my series of lecture and what we did in last lectures regarding the PGI prophylaxis and prevention. And I'm very thankful to Dr. Sinan. Everything is done in YouTube. So if you miss any lecture, you can return back to the YouTube and get some idea from that. So we talk a lot of about the prophylaxis and prevention of PGI and SSI. In our series, we talked about the wound closure and surgical dressing, and we talk a lot about the antibiotics, which is a very important subjects. We talk about the molecule and duration of the antibiotic to be given, and when there is allergy, and in case of primary or revision. And we talk about the how biofilm form in early phase of the infection, and how we deal with the bacteria which is causing the biofilm formation. Then we come to intraoperative, which antibacterial measure, washing solution, irrigation, and for the cement, and topical antibiotics where this allowed it or not allowed it, and talk about the wound closure and surgical dressing. And we say that we are the surgeon, we are working in this field, so please don't don't hesitate how to deal. In spite it is one of the major risk, major complication, but face it and solve it as person or as a team, or you refer to a specialized center. Always you have planned to start pre-operatively, intraoperatively to reach safe end result by your planning. Don't go anything without planning, so you can reduce your complication, morbidity, and the mortality. We talk about what is pre-operative antibiotics and measure, or the measures which we taken pre-operative planning for taking the patient to the surgery. Then we talk about the operative measure. All of these measures, we are talking about how to reduce prophylaxis and reduce PGI and SSI. So intraoperative, we talked about the solution for irrigation and what's percentage, what type of solution, and about topical antibiotics or with bone cement, alone or with bone cement. Antibiotic loaded cement, it take a great aspect of our series of lectures, and we reach at the result recommendation of the ICM, what we can do. This is ICM, which is carried in Philadelphia, and a lot of discussion to reach the recommendation where we are now talking about. We talk about types of wound closure and surgical dressing for the patient going to total knee replacement and with the primary and revision. And there is many open remarks regarding which type of dressing, how often should be changed, and what to in case of discharge. We say that the dressing is either passive, which is protective, or active, which is giving some moisture, or interactive, another action like vac system. Just I am showing to you for the all surgeon. This patient, I did it before 2 weeks. She came to me after 1 week. I opened, oh, of course, my plan that washing the patient before the surgery. During their surgery, I using opsite. Antibiotic is starting from the induction of anesthesia till last suture, and washing by lavage, 70 cc with 500 normal saline. So this is my plan. Just single antibiotic, nothing. So I did it. If you remember, I said with the washing irrigation with betadine and saline, there is something, I don't say complication, but a phenomena of serum. So the patient, before 2 weeks, she came to me with this. Please, when you see like that, this is not sinus, this is not infection. This is just seroma coming from the erythrotomy site. So what, after 2 weeks, I applied the principle. I stopped the anticoagulant. I stopped the physiotherapy, and I apply ice to the area. And after 2 weeks, she came to me, and this is the result. Before 2 days, this is not infection. So don't hurry and give antibiotic to the patient. No antibiotic. Just stop the anticoagulant and stop the physiotherapy. And after 2 weeks, is the patient now happy, everything is okay. Okay, we talk about what is when you are having discharge, what you can do. Pharmacological, stop the anticoagulant. Mechanical, we stop the physiotherapy. And if it is continuous for 5 to 7 days, we using VAC. If it's from more than 7 days, we going to there. And this is your principle for wound management. If there is wound drainage, 3 to 5 is, if it's less than that, 3 days, and the fluid less than 2/3 of the bag, not open, dealing with anything with the dressing. If it is continued 3-5 days, go to the VAC system. More than that, go to there. And this is wound drainage. If there is this, more than 7 days, so it's surgical, and you can, the Bradman J, just change the poly. Another session, we talk a lot about the diagnostic tool analysis of the criteria, concentrate about the definition of PGI, how you say this is PGI or not PGI. And this is kind of the surgery or kind of the patient, you face it and you see it. Why it's important? Because many of aseptic loosening is actually a septic loosening. There is occult infection. So that's why we deal with the how to define the infection, because there is a lot of cases with actually you are dealing, it is not aseptic, actually a septic. Session of diagnosis in ICM takes a long and big question mark with the prophylaxis, prevention, treatment, and antibiotic, because it's very important to know this case is infected or not infected. And I show you how can you diagnose just from the X-ray and the external looking, which is infected or not infected. And I say all of these cases is infected, but when you go to subtle or details in diagnosis, section there is in the book, there is one big section about the diagnosis from the definition, algorithm, laboratory test, pathological isolation, and reimplantation. And one of the important recommendation for all us, when there is normal CRP or ESR, just this exclude the infection. And the recommendation 100% no. This is not exclude the diagnosis of infection when you don't become happy that when there is ESR, CRP is normal, there is not infection. And we talk about the relation between MSIS in 2011 and 2008. They concentrate on CRP, and when there is CRP-SR is high, they very concentrate, especially on CRP. But in new definition, this is the old one, they concentrate that CRP is most important for clue for diagnosis. But when come to Philadelphia 2018, the philosophy change. One thing advice is no, when there is dry tap, don't inject saline to the wound. And the important also, which is highlighted over the, when you aspirate pus, this 100% infection, we say no. Maybe infection, but maybe not, because there is some cases which causes pus, but this is sterile pus. This is not infection. And we say that metal on metal, sometimes with the pseudotumor may cause pus. And MSIS definition, we say to compare for the Philadelphia and concentrate on the ESR and CRP. So a lot of experts and scientists work on definition of the PGI from 2011 to 2018, and they reach and recommend this PGI, how you diagnose or define PGI, periprosthetic infection. It depends on score, and a score from 2, 3, from 6 or 6 and above is infection. Below 6 is a query. Below 3 is not infected. 3, 5 query. Above 6 is infection. And what is done there? It's recommended about 70% from all the scientists. They concentrate in Philadelphia, new definition on 3 things: leukoesterase and alpha-dynesin, and also the dimer. These new investigation given by a score and change the philosophy. When there is change in these parameters, this means infection, and average it has point, and it's about 3 for everyone. D-dimer is 2. So D-dimer is now still working because it's new in the field, but they gave it they show the literatures that when there is infection, D-dimer is active. And actually for the rapid test, I say to for the leukoesterase and alpha-dynesin D-dimer, it's about 73% recommendation. And leukocyte esterase, which is when the simple by the urine, you can apply the strip to the synovial fluid, banned by special sign. It means this is infected or not infected. As actually, this is discovered by Perwisi and very cheap. Okay, we talk about these things, and I say all my colleagues, if they miss these lectures in detail, they return to YouTube done by Dr. Sinan to get idea to this previous lecture. So now we're talking about how when there is everything is okay, perfect, in opposite the infection, there is no infection, how we can exclude mechanical failure in good looking, painful prosthesis, painful total knee replacement. We concentrate in clinical and radiological tests that guide us to one of the reasons for the painful. And we say this is a good looking painful knee. Everything is perfect, but still the patient suffering, saying there is pain. When you look to the X-ray, when you look to the parameter, everything is normal, but the patient suffers. There is painful knee. Look, when you are looking to some like this picture, Mona Lisa, half of them is true, half of them is fugue. From the first looking, it is same. So if you want to know which is fugue and which is really, you must go to the details about the condition, and in fine touch, this is different from the original. This is not different. So we are talking about subtle, يعني أشياء دقيقة, delicate and details to reach the cause of the painful knee. By looking, it is normal, but to reach what is causing this pain to the patient, so we need going in details about the parameters which guide us and lead us. This is actually, and I hope everyone to picture it, this is done by Clevens in 2014. It is 8 modality of failure, mechanical failure of total knee replacement, starting from the infection to unsuspected scenario to the breakage. By this, it is when you put it in your mind, any painful knee, if you apply this, and everyone has certain parameter that will guide you to the cause of the pain. If we, this is infection, extension, maybe this is the cause of the painful knee. It's looking normal, but to say in details, there is something guide you. If we, from the infection, extensor mechanism, step. Just for example, if the patient is stiff, clinically they stiff. So what you think from the X-rays? You suspect from, if it is a stiff, get the X-ray, and to analyze the X-ray, look to the slope of the X-ray, look to the femoral size. I am giving an example for this. Maybe there is change in the slope, maybe change in the femoral side, maybe huge, or examination flexion extension to know the degree of stiffness, and also patellar maltracking. You can buy clinical examination or by X-ray. So one of these measures lead you to know why this the knee is painful and why it is stiff. So you reach the diagnosis by simple measure, whether examine the X-ray or examine clinical examination, extension, flexion, patient, and patellometry. And according to this analysis, you reach the diagnosis. So you catch the cause and deal with the cause accordingly. We say revision is the last chance for the patient. We haven't, like a surgeon, exploratory total knee. No, the knee is open for the failure analysis according to certain cause. You must know the cause, and accordingly you go to the revision, because this is the last surgery for the patient. So what is the line to start to get these tools for subtle or to diagnose mechanical failure, and what type? We always start by the clinical history, then physical examination, to tools for uncommon scenario. There we have common scenario, we have uncommon scenario, but always concentrate on common scenario in our country. Uncommon scenarios there is, but is very little. So start from the clinical history. Always, for every doctor, especially in Iraq, we ask if the patient is, everything is perfect, but it's painful. We ask about the preoperative X-ray and compare this preoperative pain. Is it parallel to this X-ray to do the surgery? Because total knee replacement may cause the patient happy and may cause unhappy. So for this X-ray, it is about second degree of osteoarthritis. Even if you carry the total knee replacement, she will suffer from the pain, because there is no indication for total knee replacement in this. And even you do revision for the surgery, also we change to painful revision total knee. And first it is painful total knee, now we are changing to painful revision total knee. replacement. So when there is always ask about the preoperative X-ray, and what is we say it is original mistake or original يعني الخطيئة. If the building is very good but the base is bad, the building is always be conscious about it. يعني شنو الفائدة البناية زينة بس البت له الأساس مو زين. ف if you do surgery, very nice surgery, but the original X-ray, it is not indication. So this is the original mistake, and the patient always will be suffering and come to your clinic. Please, doctor, I am in pain. So please, original mistake, check preoperative X-ray is very good for successful. Focused questions. Some of the questions. When the pain started, there is difficult when we are doing rehabilitation. Just I am saying for the painful knee, one word, that if there is painful and stiffness, you may revise the surgery. Stiffness is okay, you can manage it, but believe me, the pain will still be there. You give him a good range of motion, but the pain will be still there. So always some question from the patient. When the pain started, it is difficult rehabilitation. There is difficulty that you need step by step to reach your diagnosis. There is mechanical failure or not. Where is the location? It is medial side, lateral side, anterior knee, because everything has structures. So medial-tibiofemoral or the patellar or lateral compartment. Sometimes there is associated symptoms when there is recurrent swelling or popping or giving way. This means there is something intra-articular and there is something with the ligament. By this sign and symptoms, you may reach the diagnosis. Type of the pain. It's very important to know the type of the pain. If the pain is at rest, this means infection. Concentrate in the infection, not definitely, but concentrate. If the pain is at rest, mean continuous. When it starts up the pain, this is intra-articular instability. When the patient starts coming out from the chair or the bed, or when he's climbing or descending from this is the problem of the maltracking. If the pain is coming from this movement, when there is weight-bearing pain or non-weight-bearing pain. If there is weight-bearing pain, you concentrate for the alignment, ligament, patellar ligament, quadriceps, you concentrate in it. And then the pain is localized to the knee or it's diffused. So you need to know where you concentrate in your examination. This is regarding the history for the pain, where type of the pain, and when the pain starts. Then we come to the physical examination. It is very important. Believe me, when the patient comes to me for examination, before I'm asking about his knee, I'm asking about the back. I'm asking about the hip. Why? Because maybe there is associated sinus from the back or the hip. So when you achieve the surgery, still the pain will be there if there is in the hip or spine. Because the patient tell me, okay, doctor, but this pain is not proved. Then you think about maybe there and there. So preoperatively, please examine the hip and the spine and tell him, أنا دائما أقول له هاي كرخ هاي رصافة. When you are going to correct the knee, the pain from the knee will be disappear. Regarding the pain from the back, still paresthesia lila or the hip. The problem is different. So please, before that, check the back and the hip. Access for the instability, also inflection. Why inflection? because till 50 degree there is capsule tension and prevent you from the vague condition from the capsule or not capsule. So when you do 15 degree, you eliminate the job of the capsule. So you can concentrate on the collateral ligament, MCL, LCL, ACL, PCL, according to the type of the surgery when you are CR or LPS. So it's important in examiner to know the situation of the ligament, where it's lax or not lax, where it's tight or not. About the patellar maltracking, it's very important to do examine on flexion, so to know excrusion of the patellar tendon and patellar is going out from the tract or in its tract. What's about the patellar clunk? The patient, a lot of patients coming, especially we are not resurfacing the patella, coming saying something, giving way, pop, or clicky sensation there. For the patella, which is not resurfaced, it is natural phenomena. There is, because this clunk, if you observe it, it is anterior from the patella, sino-anterior to the patella. So, in how it's happened, mechanism, this is coming under the patella. Look. So, in extension will be disappear. In flexion, it's in front of the patella. In extension, disappear. So patella jumping and going. She's feeling something unstable, but it's actually clunk syndrome, and it is from type of severeness from the simple cricky sensation to jumping of the patella. So it's common for the patient not doing resurfacing of the patella, some of the patient. What's about the stiffness? Actually, previously, it's still 90-degree flexion is accepted. So you doesn't say that the patient has stiffness, but now the patient needs some extra activity when sit on chair, down, or praying or something, want to sit on the ground. So till 90 degree is not accepted. So flexion often it needs to give 120 or more. So mild stiffness till 90 degree, there's flexion may initiate the pain. So you must deal with the condition or type of the implant, high flex type or not flex type, to avoid complication stiffness. Then we go to another tool, blood test and joint aspiration. And I don't want to concentrate because of the infection. We have a lot of talk about this. A painful total without detectable mechanical cause should be considered to indicate infection until proof otherwise. Like amenorrhea is pregnancy until proof otherwise. Mechanical failure is infection until you prove otherwise. So regarding CRP, you must have an idea. CRP will be normal for 4 weeks, after 4 weeks, but there is false positive and false negative. And we say that if there is ESR or CRP is normal, this not exclude the infection because there is about 7 to 10% still there is infection. So you must carry painful normally, but you put the infection in your mind, do the aspiration from the hip or do from the knee, and you send aspiration, as we say, to the leukocyte count and the count and differentiation with the culture and agar 5-day brain heart tissue 15 days. And also, if there is normal, if it is normal, you can repeat the aspiration if it is unclear. From this study, you look, the First aspiration is 50% infection, the second aspiration 75. So this means sometimes low-grade infection, it needs time to be definitely diagnosed. You can repeat aspiration, even it is normal. Don't be happy, this is not infection. Can repeat the aspiration. There is a simple test to differentiate between infection or intra-articular something structural instability by lidocaine test. Whenever we do aspiration for infection, you can inject lidocaine about 10 cc intra-articular. If the pain disappeared, this means no infection. This means there is something, maybe micro loosening is not appear in the x-ray because the patient after 10, 20 minutes, he will say, okay, my pain is disappeared, and he can walk. So by this test, you differentiate between the infection or something intra-articular like micro loosening, or there is crack on the bone cement, something minor thing that cause the pain will be disappear. We come into the X-ray. X-ray is very good rule to diagnose most of the painful knee, maybe by simple X-ray or something sophisticated. One. So by standard X-ray, it is always important to get an X-ray that series of X-ray you must have, and you must have preoperative, postoperative, and a long period. So by simple X-ray and follow, you can get multiple causes for the painful knee: alignment, loosening, osteolysis, patellar maltracking by simple X-ray. And also, when you examine previous X-ray, you may follow it. This is post-operative, 1 year, 3 years. If you observe, there is some osteolysis of the medial aspect. This is less, this is less, this is very less. So it's increasing gradually. By serious X-ray, you may get the diagnosis, and this is the cause of the painful knee. In spite, it is looking normal. Sometimes you need the flora. Flora align, but must be perpendicular to the knee. So you get the loosened line. Because sometimes X-ray gives you not pure lateral, so you miss the causative factor. If you have a flora, you can get the loosened line, and this will cause osteolysis and instability, and this is the cause of the painful knee. And this is also, if you carry it in weight bearing or valgus stress, you see this is the loosened line, and there is something loosening between the implant, and it means between the bone cement. Even the radiograph diagnosis, because wedge shape bone resorption, this is a guide for us. There is infection. If you learn, this is medial wedge resorption. This is also help in diagnosis. Sometimes when you see periosteal scalloping anteriorly and posteriorly, also this guide you. There is by simple X-ray concentrated, you get the causes, why it is painful knee. What's about stress X-ray? It can you get varus or valgus or weight bearing. So get an idea about the ligament laterally or medially or weight bearing, about the situation of the tibia and whether there is loosened line or osteolysis in stress film. What's about patellar maltracking? There is a different view. You can take the patella, how to take the patella X-ray to know whether the patella in the trochlea or subluxated or dislocated. And this is, you can, by simple merchant view or modified, this you can get the patella weight bearing, because sometimes when you doing non-weight bearing, you not catch the patellar malalignment or patellar mal-tracking. If you see this, this is in non-weight bearing, but you when you carry the weight bearing, so look, laterally is catched. So there is friction abnormal, and there is minor patellar maltracking, and this is the cause of the painful node. And another cause, look, and this is non-weight bearing, medial lateral, and when you go by weight bearing, patella, hamstring, to laterally and causing subluxation of the patella. And this is also a non-weight bearing. In weight bearing, there is problem in maltracking. Okay, when the patient come to you to anterior knee pain, most of the surgeons say, oh, okay, this is the cause because I not resurfaced patella. This is the cause of pain. Always shift to this cause, but this is last thing to be guided to this diagnosis, because we say surfacing, resurfacing, it is a philosophy. You can carry or not carry. If you carry the resurfacing, the complication will be maybe, where is the thin bone, maybe crack, fracture, and everything is disaster. And will not resurfacing, there is sometimes Clunk syndrome, or sometimes medial or lateral patellofemoral ligament disproportion. But not going from your mind, primary anterior knee pain, this is okay, resurfacing, I must do revision, just resurfacing the patella, and you miss the original cause. And there is another tools. I don't want to talk about nuclear medicine because in Iraq we missed actual centers for examination. But the nuclear medicine is advised not to be carried before 1.5 years because gives false positive results. So even if you want to do it, please, you can manage it after 1.5 years. So the result will be perfect more. What type of the bone scan? The most important and most sensitive is labeled leukocytes. This is most sensitive for diagnosis, but actually I think a lot of centers we haven't this. PIT still need you to examine and get the causes of painful knee and help by PT. What's about the CT? CT help for two aspects. First, for the rotation or osteolysis. And the radiologist must understand the important thing, not the rotation, and the degree of the rotation. And the femoral is more sensitive for the rotation more than the tibia. So the line between epicondylar axis and the line of the posterior condyle, to know, that's why we are always doing 3-degree external rotation. But CT sometimes give us information of the malrotation for the femur and the tibia, and also help us for the, sometime for the osteolysis. If there is CT in painful knee. And also sometimes there is manual X-ray. Can we take it to see the rotation? But the mechanism how to take this X-ray. What's about the MRI? There is MRI Mars, which is metal artificial reduction sequence, or normal MRI. What is the benefit with MRI in painful knee? Is actually when there is which we needed sometime we send the patient for the MRI to check whether there is painful. Is actually this is the conventional. This is the new technique. When there is extensor, to check the extensor mechanism, where there is tear or weakness of the extensor mechanism, or sometimes where there is pigmented volnodular synovitis, and check it if it is posteriorly or anteriorly, and this may cause the pain, or sometimes for the synovioma or osteolysis. So MRI, we send in painful knee if we have swelling around the knee, and there is reduction of the activity of the extensor mechanism. So to check the extensor mechanism. Coming to the uncommon scenario, if everything is perfect, what is the other causes of painful knee? Sometimes there is, actually I don't see in my experience, when there is a scar neuroma, sometimes there is, and causes severe pain, and when you remove it, the patient relieves from this pain. Or sympathetic dystrophy. This is what I am saying uncommon scenario, because don't guide your mind to this uncommon scenario. There is common one, let's to go tools for this common one. Then if everything is perfect, you can think about that. Regarding pseudox dystrophy, the pain is disproportional and it's stiff, and there is hyperhidrosis, hypothermia, or discoloration, and there is atrophy of muscles. These criteria let you to think about sympathetic dystrophy. And there is also patchy osteoporosis of the bone. And when you do sympathetic block, everything is abolished. Another uncommon scenario is hypersensitivity to the metals which present in the knee implant. دائما المرضى يسالون دكتور هذا بلاتين اقدر اسوي اكس راي؟ دائما هي سبيكه، مو مجموعه كروم كوبالت، فسبيكه، ولهذا ما تصدع. وشيء ثاني، you can take MRI freely without any complication. دائما يسالون يصير؟ نعم يصير، تاخذوه وما له اي تاثير اذا MRI الظهر cervical or spine، لانه هاي سبيكه amalgam. It is not a metal، لهذا ما تتاثر لا بالMRI المagnetic field لهذا، ولا تتاثر X-ray. Hypersensitivity, so allergy to some component of this implant, it's happened, but sometime يعني نيكل موجود بال سميث اند نيفيو يصير كوبالت كروم بعدين يعني السمنت، but it is a less complication. The last thing is to think this is psychogenic pain. Please let it, the last thing, psychogenic pain. Maybe the patient is, everything is okay, but you say this is psychogenic until you do every measures to diagnosis and everything is perfect, and go to the history of the patient, what type of drugs taking. So that's why you can take this is psychogenic patient. So for the algorithm, we talk for the failed total knee replacement or painful knee. I told you 8 modality of the failure. So start by history and physical examination, serial X-ray, lab tests. If there is normal, go to aspiration, inject dilocaine, and then you go to CT or MRI. This is your guideline for every painful knee. And as I told you, the first schedule, you can check it and put it in your pocket. Whenever you think that your job is perfect but still painful, these things you can do it. And if everything is okay, okay, you can say psychotomy. Let me just show, this is always we used to, one of the cases we suffered and what is done. A 72 years old lady with uncontrolled diabetic and impending renal failure with fracture of left femur 3 years ago. Actually, the patient not represent is done by other surgeon, and even accordingly, she had this risk factor. Always we say this. We talk about the risk factor, diabetic. What is the guideline of us? 7.5 or 7 laparotomy, and correct if there is something renal or anemia. So they carry and what she had actually fracture of the simple fracture of the femur spiral, and the surgeon, with the presence of risk factor, he did for plating. Very nice looking for the plate. Okay. Flexion, infection, foreign body infection, plate infection happened because there is risk factor and it's happened, the infection. Maybe renal parameters not corrected or the fluctuation of the blood sugar. After friction, they remove the implant and put external fixation. Perfect job. And it is, this is the rule, what we do. She actually traveled outside Iraq. They advise for her, the fracture site is still not healed. So, you know, outside they're thinking merchant, financial. What they did for her, intramedullary nail they remove the plate and change it to the intramedullary nail. And they did, by their way, they say that you have arthritis, so let us to do for you total knee replacement. So we have now intramedullary for fracture not healed, patient with risk factor, renal and diabetic, and we apply total knee replacement just for the X-ray having arthritis. Infection, continue. What they did for her, they remove the implant and put mobile spacer. The fracture is still not healed and intramedullary foreign body left inside. So their philosophy that keep the fracture to be healed and we change just the mobile spacer. So the infection is still continue, not healed. This is the screw of the intramedullary. What they did, they removed the spacer. But at this time, because you know, multiple surgeries, there is osteolysis and there is a lot of bone loss. What they did for her, fixed the spacer. Just put the bone cement and some sort of the K-wire to the tibial canal and femoral tilt area, which we allowed it by the intramedullary nail, because it's still sinus and pouring of pus. So respacer. Infection still there, and because the risk factor is still there and there is impending renal failure. During this period, the patient is actually treated for the medical department for her diabetic and renal. But we know it is visuous circus. Diabetic causes infection, infection causes diabetic. Renal impending failure causes infection, infection. It is visuous circle. So presented to me and I did everything. Also, there is pouring of, and after 1 year and 2 months, still there is pus, and actually the bone cement exposed from the bone. The wound is dehiscent. Okay, what I have, I correct. I actually I left the medical department to correct the glucose because I don't carry before 7.5, and some correction to the renal still because creatinine remained 1.5 and blood urea about 70. But the anesthetic told me she's fit for surgery. We did for the surgery, and this is the inside bone cement. We did debridement and removed all the infected tissue and bone cement, and I removed the nail and I removed the sucker because it's foreign body inside, and you know it's one of the causes of the infection. So and the fracture, I say it's about 70% is healed, but there is some movement. That's why after, this is the biofilm we talked. If you look, this is the biofilm layer, which bacteria behind it. So we correct and clean everything. We removed all the dead tissue, and we applied fixed spacer with external fixation, just to hold the fracture and just some fixation to the joint. And this is after 2 weeks or 3 weeks after surgery, and this is bone cement inside. The bad news, the patient died because of septicemia. That's, we are waiting for doing the surgery for her removal and RHK to be applied to her, but actually before 1 month passed. That's why I am talking in the beginning, prevention, prophylaxis, everything to avoid the morbidity and mortality. Simple fracture of femur lead us, this is disastrous situation, and we lost the patient. Whatever the cause, it is lesson for us to get the guidelines, especially for the infection. And the patient before 1 month, actually, she died. After this lecture, please, this is my phone number, and this is my email. Please, all the doctor, my colleagues, my student, my teacher, and anything you have to dialogue to discuss with me, whether primary or revision, anything, you can write to email or write to me, and we be as a team to manage and achieve success for every case. If you have complicated, please don't hesitate. Write, email, or as a message that we can be a team. I can help you in surgery, or I can help you by our idea. This is the work of the team. Thank you very much. Dr. Sinan, now the phone with you.
Thank you very much, sir, about this wonderful lecture and very nice and interesting case. Actually, we have some questions, but first of all, I think the case you mentioned about, it was not an indication for total knee surgery, right, right, sir?
Yeah, that's why the last يعني نهاية القصة we lost the patient whatever the causes.
يعني البرايمري
احنا ما نريد ندخل
عشان هو
بالديتيلز.
indicated
قلت لك financially برا they think financially هم
yes.
جايين على fracture. Okay, you have arthritis and this causes the pain, and they did for her also totally. That's yes, not the indication. Just we can treat the fracture and everything. And this is the tragedy. قصة لكن درس علم.
Yeah. Okay, we will receive your questions in the chat. If anyone have a comment, please just make a raise of hand and I will give the mic to him. عندنا سؤال دكتور سيف نبيل. Is there any specific zones for aseptic loosening in a knee, like the X-ray in the hip for Gowen and Lee Chandley? السؤال هو عن ال zone of loosening regarding the total knee replacement.
اكو loosening
اي يعني هو ده يقصد ال area of loosening around the implant postoperatively. اكو هيك شيء يعني like that of Gowen and Delete and Chandley in the hip.
الهip والknee it's same.
The same, yes.
Same. There's a, but in this case you get benefit from the serial X-ray.
Yeah.
لأنه maybe you leave this zone مرات بونسمنت لما هذا يمكن برايمر أنت يعني صاير تعوفه.
Yes.
فهي هاي النفس ولا. But serial X-ray the progress in loser zone lead you to diagnose that painful knee. أنا دا أقول دائما this is painful knee also painful hip. Chapter نفس chapter hip.
Yes. Yes, thank you, sir. I want to share a screen of the X-ray of a total knee with loosening. حقيقة هي ما أعرف يعني بدأ يصير عندي sharing على مود الدكتور سيف يشوفه. القصة وين أستاذ؟ إنه إحنا بالتوتال ني in AP and lateral views الأكثر loosening هو بالتيبيا. والتيبيال تري اذا كانت بالميديال هي نمبر 1 يعني او جريد 1 اذا كان lateral جريد 2 والتيب هو 3. هذا بالنسبه للاي بي فيو. but in the lateral view we may see that it differs يعني ممكن يكون يعني هو اكثر من واحده الى 3 بس هي in general 1 2 3 هي لحد ال 7. So you have in the lateral view the anterior 1 posterior 2 and the tip of our the stem هو 3. Regarding the femur, yes, there are loosening يعني نبدي بيها من الانتيريور chamfer والposterior وبعدين همينا التب. فهي هذين الزونز يعني it is only theoretical. The most important thing is that when you have a loosening, aseptic loosening, you have to be sure about it is aseptic first. Whenever you have it and with a pain, symptomatic, you have to prepare yourself for exchange the implant.
تدري هم ارجع على serial إذا big وأدى إلى osteolysis so there is pathology in the area.
Okay, دكتور محمد قحطان, do you say recommend polyethylene exchange and impaction bone graft in a single large osteolysis without impending catastrophic failure?
شو تسوي له؟
السؤال هو انه نقدر نسوي polyethylene exchange with impaction of bone graft in a single large osteolysis. For example, بالتيبيا إذا كان عندي large single osteolysis but without catastrophic failure.
شوف البون لوس يعني البون الاوستيولايسيس يؤدي الى بون لوس.
Yes.
لهذا يعني انت اذا تفكر بس بولي تشينج الستيبيليتي ما راح ينطيك اذا انت بس جيت خليت امباكشن بون جراف. ولهذا سوي له بروفيجن ولونج ستيم اذا وياها يعني اوجمنتس او يعني بون جرافت but huge amount of يعني ما عندنا احنا عليه huge amount of bone graft بس stability for the bone loss. It is not just compensation شلته وخليته لا السيجما التيبيا الامبلانت is weak so لازم تسوي له revision and long stem until stability. stability اريد
هو ذكر
البولي it is not just enough for this surgery.
هو أتذكر يمكن واحدة من ال MCQs in AAOS suggesting that without catastrophic failure you can exchange it. بس هو تعتمد بالضبط مثل ما قلت أستاذ على ال area of the osteolysis. أعتقد دكتور عماد حسن he's asking for the mic. دكتور عماد أهلا وسهلا أستاذ.
Thank you very much, Dr. Mahmood. Assalamu alaikum.
Thank
you very much for this informative lectures. Thank you very much. Just I want to speak about there is you must radiologically deal with the lucent zone or lucent line below the implant. In the case of septic or aseptic loosening, in the early postoperative period, sometimes due to hyperemia, due to form body like implant, فمرات يصير بوروسيس يعطي راديولوجيكال فايندنج بانه هذا لوزنج. ليتر اون يشوفها بانه شوي شوي يصير يصير نورمال ويرجع كانما ماكو اي لوزنج. فالديفرنشيشن بيناتهم بانه يكون ذاك اذا كان لوزنج اسبتك اور سبتك يصير عنده بيزار شيب بوروسيس around the implant. Thank you very much.
شكرا لك حبيبي الدكتور. لا صحيح بيرفكت. ذاتس واي قلت لك انا سيريال اكس راي للمتابعه، لانه برايمرلي احتمال عندك هذا الزون وهذا وده تريد تتابعه،
وهذا الزون يبين لوسنت كانما انت تتوقع انه هذا لوز.
بالضبط. بالضبط صحيح دكتور عماد صحيح.
Okay, thank you, Dr. Ahmad. We have another question, Dr. Soran. What is your strategy? Where is the question? What is your strategy for revision regarding one stage or two stages? دكتور سوران هو بس لو نحدد إذا كان infection or not، لأنه هو هذا الموضوع مهم.
أعتقد عن infection ده.
I think yes, two stage. Yeah.
I am two-stage surgeon. يعني one stage is بيها كريتيريا وبيها مجازة في الحقيقة، لأنه هي 70% نسبة percentage of success، ذاك 90%. بس it is two surgery, two anesthesia, يعني two stress for the patient, but I am relaxed. In one stage, always you are in aware، يعني تحت إنذار. Maybe there is infection. It needs very demanding surgery, huge debridement. والأهم شيء إنه المساعد مالتك يكون كل الشجاع ويشجعك نظف. لا مو يوقفك يقول لك لا كافي ولا. I am to stay surgeon all of my cases and I will never do one stage.
One stage أستاذ هو يعني مثل ما قلت هو موضوع يعني very limited حتى لو بالelderly, and especially if there is an infection with a low virulent microorganism, you may have يعني the biofilm has been started, so it is not a promise that even when you have a low virulent microorganism that we have an aspiration or with biopsy وطلع positive with a low virulent, you cannot do one stage only. You have not proved that this one stage will eradicate the infection. لأن هي كلمة eradication of infection is very difficult to know. I think yes, two stage better.
ما أشجع زملائي والطلاب والأساتذة إنه يسوون first stage، لأنه الظروف اللي متوفرة عندنا مو
سهلة. مو مال one stage. Yes. Dr. Mahmoud, I think you have the mic opened now. Please, you can speak if you have a question.
Thank you.
Welcome, Dr. Mahmoud. عليكم السلام. Hello, Dr. Mahmoud, تسمعني؟ Hello. Oh, I think we lost him. دكتور مامون إذا تسمعنا يمكن المايك هسه مفتوح يمك.
The same question. The same question.
Yeah. Yes, please.
لا same question يقول يعني.
Same question.
يعني الظاهر سألوه
Okay. Welcome. If you have another question, we are ready. Dr. Nabrad, he's asking about in revision for how long we should stop the antibiotics to do CRP and then proceed the second revision.
يعني برايمر يعني قصدك السبيسر و going to يعني تقريبا 8 to 12 weeks.
Yes.
8 to 12 weeks.
Okay.
وبعدين البارامترز infection parameters it's perfect nothing you can do the surgery.
We can do the, yes.
Because sometimes it takes long time and we have one case 6 times we did revision there is healing completely for 1 year 8 months and then she came for us there is we opened 6 times.
Okay, Dr. Ammar Sata, he's asking, dear sir, is the theory of antibiotic holiday is applicable now, like 6 weeks spacer and then antibiotic holiday, then revision?
الهوليداي العسل شهر العسل هو مكانين واحدة before aspiration 2 weeks هذا شهر العسل الصغير توقف عرفت شلون؟ بالنسبة للريفيجن 6 أسابيع تنطي وأسبوعين توقف ويستارت ذا ريفيجن وبالريفيجن تاخذ البايوبسي.
Okay.
عندنا هاني تايمز 2.
Dr. Imad Hassan, he is asking about, yes, you can share a photo please. أنا سويت الشير for all. إذا أي واحد يريد يسوي share for a picture or any photos, we are happy to. زين. عندنا دكتور بعنوان iPad. You have the mic, sir. We can hear you if you have a question. هو فاتح المايك iPad. Can you have a comment? Okay. زين. Another thing is that Dr. Mohammed Qahtan, regarding the case presented, sir, infected femoral plate, can we do arthrodesis after the reinfection in the presence of a spacer? This is a good question.
Let me tell you the truth. The patient حقيقة and I gave her advice that I can do mobile knee. I can total knee replacement. She begged. It was that الدكتور قال ترى أنا ضجت ثبت لي الرجل. طبعا one of the هذا كان amputation but she doesn't accept. قال لي ثبت لي yes for arthrodesis.
Yes.
But my plan is to do knee actually. But she said to me no please do ونسوي له intramedullary nail نخلي له سكرو فوق سكرو جوا. Yes, there is option for
yes, a good option. Yes.
For amputation and orthosis.
Yes. Okay. Dr. Loay is asking now. Thank you for wonderful lecture. So there is a period of observation in loosening. Is there a period of observation in loosening? My question is when to attack the loosening if it is seen in X-ray.
If there is a change in the implant position.
Yeah.
X-ray.
Yeah.
Yes.
Whenever you have an instability of the implant, a previous and serial X-rays, there will be an indication for surgery with the symptoms, of course. Okay. Regarding the period of antibiotic, Dr. Mohammed Qahtan, regarding period of antibiotic in all the periods should be IV, or we can switch to oral antibiotics.
According to the GM. To the GM يعني إذا فينكومايسين أنت ما عندك هذا فينكومايسين ما عندك تابلت تنطي له فينكومايسين بس كل 3 أسابيع تشيك الفينكومايسين ليفل أو التابلت ريفامبسين وعندك جليندامايسين. You can يعني تابلت according to the GM.
Okay. سر بس استاذ اذا ممكن انه بس نوقف الشير ذا سكرين لانه دكتور عماد he want to share also. Okay.
I'll stop the share.
You can stop the share. هو أنا هسه
stop
سويت
video يعني stop video.
stop لا مو الفيديو الفيديو مالتك اللي حيصير بس stop share يعني اللي حيصير هو الشير سكرين نفسها بس نسدها.
يعني أنت من يمك لو أني؟
لا هذا هو من يمك أستاذ. You can stop it.
شلون stop ولا أدري. يعني هذا الشير
أنا هسه أقدر أسوي شير ممكن.
سويه من يمك stop.
لحظة أستاذ. participant sharing, yes. Okay. Okay, استاذ هسه تمام. دكتور عماد, we are waiting for your share. Another question, Dr. Mohammed Jassam. Do you recommend, sir, about certain antibiotics that are used in the spacers?
Certain antibiotics
Yeah.
وذات
Then,
شنو؟
used in with the spacer, yes.
ما فتح بالكيس يعني antibiotic bonus loaded with antibiotic.
Yes.
Yes. You have to يعني احنا vancomycin نقول لانه multiple يعني for multiple organism تقدر or according to the germ you can mix the antibiotic which appears sensitivity to the germ with the antibiotic with the bondsment.
Yes.
But not on the wound, just with the bondsment. Yes.
Okay. Dr. Imad Hassan. استاذ عماد, هسه
ما
انت
ادري
تقدر
وصل هذا البوست.
اي استاذ هسه تقدر تشرح عنه بس على مود الصوره والصوت وياك.
هو هذا الدحكي. العفو استاذ محمود.
بس
يعني
مدى اشوف
الموضوع
دكتور عماد مدى
ماكو
اشوف
صوره.
انا مدى
صوره
أشوف.
ماكو. وصلت دكتور سنان؟ وصلت صوره؟
لحظه استاذ هسه انا اذا سويتها ما بتلخ.
وين الصوره؟
هسه تشوفوها اخوان؟
وصلت؟
انا اذا اشوفها يمي.
وين انا مدى اشوفها؟
لحظه استاذ.
وين ده تروح؟
هذا شيء يمكن.
لحظه استاذ يمكن ما بينت. لا راحت هي. شفتها اني بس it is lost. اوكي. هسه واضحه الصوره اخوان؟
ايه
واضحه
نعم
الصورة.
واضحه.
اوكي.
واضحه هسه.
استاذ عماد بس ممكن انه تفتح المايك حتى نحكي عنها.
لا العفو. هذا this is الموضوع اللي حكيناه. شكرا استاذ محمود. هو
نعم.
بالايرلير مرات يصير هالبريمه يبين بانه هذا well defined بينما ذاك poorly defined ويبدا السبسايدنس ويبدا هذا. ثانك يو فيري ماتش.
تمام. شكرا حبيبي. شكرا جزيلا. بارك الله فيك.
Thank you, sir. Okay. Is there any questions here? Let's see. Okay. Okay, I think we don't have more questions. If you have it again, you can write it anywhere and we will answer it. Thank you very much for your joining, Dr. Imad Hassan. You have another picture. This is more wonderful, yes, and this is very, very obvious. يعني الفرق بين السنة والعشر سنين هذا loosening, right, sir?
Physiological reduction.
أستاذ عماد المايك. أستاذ عماد ما أدري تسمعني؟
Thank you. This is what I want to just comment. Thank you very much.
Yes.
Yes, هو هذا physiological loosening.
Okay. Anyone have a comment or a question? Please. I'm very much thankful for you. Thank you, Dr. Mahmood Shihab, for this wonderful lecture. Thank you, Dr. Imad Hassan, for sharing new and very wonderful pictures. Thank you all.
No, thank you very much. Thank you, Dr. Mahmood.
And hope to see you next week, inshallah. Thank you and goodbye.
Bye-bye.